Well, friends, welcome to today's webinar. And today we have Dr. Sanjay Mehta, Professor at Head Microbiology Department, CU Shah Medical College in Gujarat. And he will be taking up the topic of Introduction to CBME. Over to you, Sanjay.
Thank you very much, sir. Welcome all friends. This is a group which is basically created, or we are together just to look into our CBME implementation, right? So before we actually dive into the competency and objectives, let us have some introduction about what is competency-based medical education, right? So we'll just go through that. I'll take something around approximately 40 minutes, and in that we'll discuss about competency-based medical education at international level, that is Queen's University School of Medicine, Canada. And then in later half, 20 minutes, we'll look at the competency-based undergraduate curriculum for Indian medical graduate, Medical Council of India. So with that, let us have a brief view of what is this competency-based medical education, and it is very important. So we'll be able to compare what we are doing and planning and what the world has devised this particular curriculum. So we'll be able to plan out also accordingly, and way forward would be very easy. So first of all, if you want to define the CBME, all of you must be knowing, right? This is an outcome-based approach to design, implementation, assessment, and evaluation of medical education program using an organizing framework of competencies. So the first important point is outcome-based. So we are looking not from the curriculum aspect, but we are looking from outcome, which we are supposed to certify such certain skills or competencies. So we talk about competency and we talk about outcome based. In another word, see over here, one more definition from the same author. It says competency based education is an approach to preparing physicians for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from an analysis of societal and patient need. It de-emphasizes the time-based training and promises greater accountability, flexibility, and learner-centeredness. So what is more highlighting over here is the graduate outcome abilities. So if the student acquires this competency, then they are ready to be graduated. And these competencies are derived from the societal need and patient need. Over here, you can see it de-emphasizes the time-based training and promises. So one more thing, the time-based training is being little bit compromised over here. We'll also talk about this later on. The fundamental difference between this competency based medical education with conventional or structured or process based education, over here you can see in this particular slide, the competency based education, this is outcome based. The first, the driving force for curriculum is outcome. The driving force for the process is learner, while in conventional it was teacher. Path of learning over here is both teacher and student, non-hierarchical, while in conventional it is hierarchical from teacher to student. The content responsibility is student and teacher both, while in earlier it was only teacher. The goal of educational encounter is knowledge acquisition, while in this one it is application of a knowledge. The typical assessment tool is single subjective measure, that is summative examination at the end of the course, while over here it is multiple objective measures. Assessment tool, the proxy. Authentic, that means real time, patient or simulated patients are being there, and on base of that, the assessment is done. Setting of evaluation, once again, it is real time and real. Evaluation is norm reference and criteria reference. We'll not discuss this in detail. What is that? Timing of assessment, once again, emphasis more on summative, while this is throughout the course, that is formative. And program completion, that is fixed time, and competency base is variable time. So when we talk about this competence-based medical education, the first word which comes up is competency. So what is competency? So it's an observable activity of a health professional integrating multiple components like knowledge, skill, attitude, and values. So the most important point over here, when we are devising objective, it is very clear that competency is a combination of all, while objective would be specific for a particular domain. So competency would enclose knowledge, skills, attitude, and values. Basically, it indicates the ability to do something successfully and efficiently. So competencies are a series of identified observable abilities applied within explicitly defined contexts that define a spectrum of achievement from novice to sophisticated learner. We'll also see that what does this mean, novice to a sophisticated learner. But remember one thing, that competency includes multiple learning objective, right? And that can be of different domains. So when we talk about competency, there are three words which needs to be differentiated. The first one is competency, second is competent, and third is competence. So competency is ability that must be acquired in order to do expertly. That means these are defined in a curriculum or in a program that graduate or the student will have to acquire. The competent, once the student acquires that, he becomes competent. So the person has the competency, so he becomes the competent. And when using that competency, when he performs, then we can say this is a competence. So you can understand the difference between these three words. Competence is ability. The competent is rather person has acquired the competency, and competence means he is now performing. He has performed. So should be able to do it, can do it, and does do it. So these three important words we should remember. Now, let us just have a look at the Queen's University School of Medicine, Canada, who has already implemented CBME. And over here, you can see the CBME or the competencies are translated in series of different levels. So you can see in the first one, that is goal and values, which is translated into entrustable professional activities. We'll come to that word. The role and competencies, then program objectives, curricular objectives, course and learning event objectives. So right from the hierarchical level, the highest goal, it will reach down to the learning objectives. And entrustable professional activity would also require acquisition of certain skills which an individual will have to assume the role. As for example, over here you can see the role which medical graduate will have to acquire is medical expert, communicator, collaborator, leader, health advocate, scholar, and professional. Remember these rules are different according to different countries, right? So this is what we are talking about, Canada and Queen's University. So there is a continuum, right from starting from EPA, that is entrustable professional activity, to the roles, to the competency and objective. And you can see like our competency table, it is also being translated. And over here we can see that medical expert, ME1, then program objectives, ME 1.1, and then curricular objectives, that is number 4, or there are four different type of curricular objectives. That is how the micro planning is being done. So let us start with the EPA. What is EPA? So EPA are entrustable professional activity that routinely any student or a graduate or a medical graduate is supposed to carry out during its academic work, right? While treating a patient or while doing other activity. So remember that these are overall clinical tasks that must be accomplished by the student. And once it is accomplished, he can promote to the next level. So series of EPA are developed by different universities according to their curriculum, and students will have to demonstrate they have acquired this competence to successfully complete this task, and then you are promoted to the next level. So as for example, in Queen's or School of Medicine, one of the EPA is interpret and communicate results of common diagnostic and screening tests. So I've taken an example which is befitting to microbiology. And what is the description? The graduate recognizes normal and abnormal diagnostic and screening test results. He or she, in a timely and confidential way, explains the significance of test results, respond appropriately to this test result, and communicate this information to the patient and relevant members of healthcare team. So this is one of the EPA for this School of Medicine. Now you can see that EPA includes roles which student will have to acquire, right? The role there are, as earlier said, these are the different roles, and EPA would include different combination of these roles. So over here, to interpret and communicate the results of common diagnostic and screening tests, the roles which are required is medical expert, communicator, and scholar. Now, these roles are further translated into competencies. And these competencies, as earlier, which I have shown the continuum, ME2, it talks about clinical presentation and clinical assessment competency. The graduate is able to perform complete and appropriate clinical assessment and provide initial management for patient presenting with clinical illness. So this is one of the competency within role number 2, that is medical expert. Now this is translated into program objective. You can see over here medical expert 2.1. Now we are talking about clinical assessment. The graduate assesses a patient within a clinical encounter, generates an appropriate differential diagnosis and investigation plan. Over here you can see EPA is very broad. EPA is broken down into, rather EPA requires certain inclusion of roles, and then it is broken down into various competencies, and competencies once again broken down into various objectives. We are just following one particular EPA and then going into role, then going from that role, we are just looking into one medical expert program objective, right? Competency, that only we are following. Simultaneously, there can be other few competencies in which it will go into different roles. We are not going into that, but we are only going into medical expert. So now curricular objective, coming to the departmental level. Over here you can see the graduate is able to select and prioritize medically appropriate diagnostic test depending on the urgency of patient condition with consideration of risk, benefit and cost. Correctly interpret diagnostic tests. So there are two which are relevant for that. So you can see curricular objective, it will link higher to the program objective, it will link higher to the competency, it will link higher to the role, and it will link higher to the EPA. That is how it is being translated. Now, at the end, right, when we are teaching the student and we are also assessing the student at the level of the department or at one particular level, the milestone descriptors. Milestones are meaningful. Over here, one more word has come apart from EPA, that is milestones. Now, milestones are descriptors of a progress of a student. So, what basically it says? It reflects the abilities you need to accomplish a specific task, and many milestones are integrated into each EPA. So remember, over here we are talking from broad EPA to role to competence, then program, and then educational, rather the last competency. While milestones are there, they are highly specific, and basically they will help us to overall the plan out teaching, learning, and assessment. So remember, because EPA is very broad and it is very difficult to teach it at one go. So EPA has to be broken down into the milestones. So you can see over here the milestone, they are descriptors for a particular test. This is selection of a test. The students is being taught in different terms, right? In term to, as for example, identify the methodology and significance of key diagnostic investigation. Term 4, select potential investigation relevant to the clinical presentation. Term 5 to 7, select appropriate tests to refine, investigate differential diagnosis. Very similarly, you can see there are more for interpretation. Term 2, selection of a clinical presentation, investigation, and you can see over here, interpret, respond appropriately, and communicate result of common diagnostic test. So you can see over here that EPA, role, competency, program objective, curricular objective, and milestones. And around milestones, there are teaching, learning, and assessment activity which is going on. You can see over here in this particular table that all teaching, learning, and assessment happening, and this is happening in a way that students are progressing from a low level to high level in which they will acquire the skill. So setting over here, you can see from classroom to clinical setting, subjects you can see from theory to actual patient, stability, you can see the stable patient to unstable, from simulation to actual patient, single clinical presentation to multiple clinical presentation, communication barrier, you can see over here, he is simply describing that and he is managing that. Level of supervision is very important. Over here you can see in a low level there is a direct supervision, and over here there is no supervision or rather indirect supervision. So everything is moving around this milestones, and that is how it is being taught and assessed. The most important part in competency-based education is assessment. The assessment is very frequent and it is a formative in nature. So it will go along with that, along with the study, along with the curriculum, along with the program. And you can see over here, there is a competence committee which will look into the record of a patient, record of a student, and would advocate whether he has acquired the skill or not. There are work-based assessment, and there are low-stake examination also being going on. Now, how milestones are used for examination purpose. This is one example. This is actually for postgraduate student, but you can see this is just for example that low level to high level, right? It observes and assists identification of microorganisms of all group, and over here gradually is proficient in microorganism identification, right? So this is how during their progress they are being assessed by various group of people. You can see that is direct observation, 360-degree evaluation, quality assessment result, identification of unknown. So various different type of assessments are used. Remember, once again, it is not a single type of examination taken at one time which will decide whether student has acquired the skill or not, student has acquired competency or not. So once again, you can see over here one particular EPA into domains of competency, that is different roles, then competencies, and competencies later on broken down into milestones. These milestones are measured regularly, and ultimately it will lead to a certification of a particular skill for a student. So this acquisition of a skill can be explained by a Dreyfus model, which we have talked about earlier. You can see over here, novice is getting into a last level, that is mastery level. Initially, he simply recognizes the feature, and at the last, he has got the highest level of performance. And this is independent. And not only that, he will be able to train others also along with that. You can see in this particular model, it is very important the progression of a novice into expert or a master, and it is being divided into various stages. And at all the stages, there are milestones, and you can see the curriculum, teaching, learning, and assessment is moving around that one. So according to the level, student will progress over a period of a time from a novice to the master. And this ultimately would fulfill the Miller's prism of clinical competence. We have all of us have seen this, right? Miller's pyramid: knows, knows how, shows, and does. Over here, we are also talking about attitude, skill, and knowledge. So this becomes a prism. And over here, you can see a novice getting into a course. And once he acquires all the skill, he becomes expert at the end of the course. So this is in brief about what is there in School of Medicine, Queen's University. Over here, I'm just pausing for some time. There is one picture, and I want you to reflect on that. Yes, sir. Very, sir.
Yes. Any questions, anyone?
I want them to answer this with regard to CBME.
Yes. Dr. Mehta has shown this picture, and he has explained you the CBME. Would anybody like to correlate with this competency with the steps Dr. Mehta has pointed out? Please raise your hands, or you can type in the WhatsApp group also. Yes, Dr. Sumati Santosh. Please unmute yourself. Dr. Sumati, please unmute yourself. Yes. Please speak.
The musician who is performing.
Yeah, is a very famous. Yes, yes.
Without any supervision, who is performing?
Very right.
Individually, he is performing.
Okay. Okay, I'll just give a name of that musician. He is a very famous musician Kenny G, right? You must have heard. Now, I want you to relate with CBME. Hello?
Yes. Dr. Mukesh.
Yes, sir. I think the musician is competent to play his instrument with confidence and without any his enough to play, sir. I think.
Right, very good. Right. So, can we say that a musician is competent?
Yeah, he's competent to play the instrument what he's playing, sir.
And
The
he has also
particular
gone,
instrument what.
yeah, he has also gone to a master level. He is performing.
Yes, sir. By independently, sir.
Yes, very right. So you can see over here. Suppose in our present medical education program, right? Kenny G gets an admission into MBBS. What would happen to him after 5 years?
This musician, sir.
Suppose we are not running a medical college and we are running
Correct.
a musical school.
Yes, sir.
Would you expect this Kenny G to play independently and performing on stage?
He can, sir.
Yes, okay. But definitely. So this is the sheer purpose of competency-based medical education. Thank you very much.
Thank you, sir.
So yes. So what we are envisaging over here is that if one person is joining the musical course, the last thing which he should acquire, he should be able to perform it, right? Like a
Yes.
master, right? So there are several loopholes in a medical education system which is currently and which is being driven by the curriculum and subject. Many a times we wonder, are the students which are graduating from the curriculum are becoming competent? Are we checking that competency at any level? Yes, definitely, but not as per the design, CBM, right? It is happening, but not exactly. So this is an excellent example of why the CBM is important, why there is a need to change the overall curriculum, and how the curriculum design has to be planned so that particular student would be able to acquire the skills which are necessary, right? You don't want
Yes.
Kenny G to go on writing everything and saying everything. What is supposed to do is stand on the platform and then play the music. Very right?
Right, sir.
Okay, thank you very much. So
Thank you,
now
sir.
we move to now we move to our scenario, which is big. Medical Council of India has recently come up with competence-based medical education curriculum, and in which you can see very like to that Queen's curriculum, we have got a goal followed by a role, followed by competency, and followed by objectives. So, first of all, Indian Medical Graduate Training Program. The objective of this program, the undergraduate medical education program, is designed with a goal to create an Indian medical graduate, IMG, possessing requisite knowledge, skill, attitude, value, and responsiveness so that she or he may function appropriately and effectively as a physician of first contact of the community while being relevant to global standard. And this objective has been translated into national goals, that is A to E, institutional goals A to K, and learner goals, that is 1 to 5, right? The learner goals can also be termed as the roles, and there are 5 roles which are being defined: the clinician, leader, communicator, lifelong learner, and professional. We're not going detail into that. Further, you can see over here, these roles are translated into global competencies. And these global competencies, there are 15 competencies within clinician, 6 within leader, 4 within communicator, 5 within learner, and 5 within professional roles. Now, these are global competencies, and these global competencies are now further translated into sub-competencies, rather subjective competencies. All of us have seen this one, subject competency, and this is the table for that. Competency, domain, then level, core, yes or no, suggested teaching learning method, assessment method, number required for certification, vertical integration, and horizontal integration. So we'll have an example once again with relevant to microbiology. The national goal at the end of undergraduate program, the Indian medical graduate should be able to recognize health for all as a national goal and health a right of all citizens, and by undergoing training for medical profession, fulfill her social obligations toward realization of this goal. Once again, right from objective, we will go down slowly into microbiology. Right? Institutional goal: the Indian medical graduate coming out of medical institute should be competent in diagnosis and management of common health problems of individual and the community, commensurate with his or her position as a member of health team at the primary, secondary, or tertiary level, using his or her clinical skills based on history, physical examination, and relevant investigations. Learner, that is goal for the learner or the role, IMG must be able to function in the following roles appropriately and effectively. 2.3.1, clinician who understands and provides preventive, promotive, curative, palliative, and holistic care with compassion. Now, further, it will come down to global competency. IMG demonstrate ability to choose appropriate diagnostic test and interpret this test based on scientific validity, cost effectiveness, and clinical context. Hello?
Please mute yourself.
Kindly mute your microphone, please. Okay, so now we are coming to what we are proceeding towards during this course is sub-competency, right? Now there is a role of the department, and over here you can see right from top we have come down to this one. So this one is directly linking to the objective of the Indian medical graduate program, right? You can say this is not the one, but there are several threads coming from the source, and this is one of the thread. So in this competency, you can see MI 1.2 subject competency, perform and identify the different causative agent of infectious diseases by gram stain, Zn stain, stool routine, microscopy. So domain over here is skill. It can be a knowledge, attitude, communication, but over here we are talking about skill. The level, it can be knows, knows how, shows how, and perform. This is Miller's pyramid. We are looking for performance. Core, it must be achieved. That means yes. And if it is desirable, no. So over here, it is yes, core. Teaching learning method is DOP, that is demonstration, observation, assessment, and performance. We'll talk about this all later on during the course. Assessment is skill assessment, and numbers required, performance number is 5. So this is what is important, understanding the subject competency which is being given. Remember that this is on which we are going to focus. This is on which we are going to teach the student. Student should learn this, and this is what to be assessed. And remember, if it becomes type of a milestone, right? Ultimately, it will link to the higher translation into EPA type. EPA is not defined in IMG, but global competency. It will lead to acquisition of global competency. So over here, we can see sub-competencies in microbiology. We already seen that general microbiology, immunology, there are 11, CVS and blood 7, GIT and HB 8, MS and ST 3, CNS 3, respiratory 3, GU and STI, that is 3, zoonotic disease and miscellaneous, there are total 54. So there are 54 outcome or competencies which student will have to acquire while he is there in second MBBS in microbiology subject. Along with that, there are other competencies which needs to be integrated. You can see over here, the first year, there is one competency from biochemistry. In second year, there are 14 competency, 9 from pathology and 5 from pharmacology. In first year, there are 9 competency from community medicine, and then maximum number is from second, final MBBS, and there are total number 127. And out of that, maximum is from general medicine, 60 competencies. Overall competencies which needs to be integrated is 151. Remember, there are certain competencies which are coming from first year, right? So it has to be reinforced. And there are certain competency which are taught along with other subjects. Over here, we should look for temporal alignment, right? And also nesting and sharing. And then once again over here, there are competencies which are coming rather starting from second MBBS and then terminating in final MBBS. These competencies are to be introduced from microbiology. The certification will be there in their respective subjects, but it needs to be introduced by microbiology subject. So total 151 competencies which we need to put it in our teaching timetable, teaching learning timetable. Now, if you look at the time, this is second MBBS. Most probably would start in October, but we don't know about this year. October to August, hardly 11 months time we have got, and probably if we get the student admitted in time. And these are the teaching hours which are advocated by the Medical Council of India. Lecture is 70, small group teaching learning is 110, self-directed learning is 10, total making 190 hours. So remember, 190 hours for 54 competencies, right? So it absolutely required that the competency needs to be expanded in such a way that these hours are also being adjusted and the competency also gets represented during this teaching learning sessions in microbiology. So with that, the task ahead with us is very difficult. till now we are talking about various subjects and competencies. Now what will happen? These all competencies need to be translated according to the role, right? Clinician, leader, communicator, lifelong learner, and professional. Various global competencies need to be translated, rather to be connected, ultimately leading to Indian medical graduate acquiring all skills and competency which is depicted in competence-based medical education curriculum, right? So thank you. With that, I end my presentation over here, and we can have a discussion on this, sir.
Any questions? Please raise your hands. Or you can write in the chat group also. Yes, Dr. Jaya Banerjee.
So what about the term exams, when to take?
Yeah, so as per our CBME program, there are 3 exams to be conducted. So what we are planning is approximately 3 or 4 months, and there would be 1 internal exam, 3 and 4 months, second internal exam, and 3 or 4 months, third internal exam or prelim examination.
Okay. So it should be practical based, right? So
It has to be both, because if you look at our curriculum, rather new IMG curriculum, you will find there are both written and practical assessment. Both are there. So it will be a combination of that. Theory as well.
Okay.
Yes.
Okay, fine. Thank you, sir.
Welcome. If I say this is not actually the 100% CBME, it is a hybrid type, because still we are maintaining subjects, still we are maintaining time, and even in a Queen's Medical School it is very similar, right? But there is more emphasis on formative assessment rather than summative. Still over here we have got a high-stake examination, or more emphasis on summative examination. Yes, any other question or any suggestion?
Yes, sir.
Would you like to add something? Yes.
Sir, Dr. Mukesh here, sir. Hello, can you hear, sir?
Yes, yes, yes.
Yeah, sir, I want to know, as you say 190, so there will be lecture, a small group, and UAPS. Sir, my doubt is there, how can you decide that because to make it informative by among the microbiologists in India, that this topic, yeah, this competency, all of us will be going to take as a small group. This competency, all of us will be taken as a. हो सकता है कि somebody will taking that as a DOAP, somebody is taking as a small group learning, and somebody will be taking as a lecture. तो वहाँ पे discrepancies आ सकती है.
Yes, yes, you are very right, because see, Medical Council of India has given the work up to a subject competency, right? And there are teaching learning methods also being indicated in that particular, if you have seen that.
Yes, so they've given options are given there, either ability or like that. So which one you should generally choose?
Remember, one limitation is that we should not exceed 70 lectures, right?
Yes,
and
yes.
When you feel that, as for example, if you think about arboviruses, there are large number of arboviruses, and what is important for them, they should know about that, as for example. So preferably you take it in a lecture. But if suppose it is tuberculosis, then better to go for a small group teaching learning, case-based learning or other. It is very important, very core topic, and you want them to learn in depth. But definitely there will be Definitely, there will be a large variability, right? Because it is
Yes,
left
right.
to the different institutions. Yes, and that is why we are
Yes, sir.
here together. That we can as far as possible, we can make a uniform schedule.
Conformity, so that I prefer that I should go for DOAP for gram staining. Maybe somebody will, instead of that, they'll be going something else है. तो उसके थोड़ी changes problem हो सकते हैं. इसीलिए
हो
अगर
सकते हैं.
हमें common बनाएं, so that will be better that, because if I go to take exam somewhere else, वहाँ पे teaching अलग हुई है, assessment अलग है, but what we have applied, तो वहाँ problem हो सकती है. Conformity को हमें, मुझे लगता है कि as a microbiologist कहीं ना कहीं सर हमें, तो एक्चुअली जो हमारा प्लेटफॉर्म अभी डिसाइड हुआ है, दिस इज गुड सो दैट देयर विल बी इनफॉर्मिटी मैक्सिमम कॉलेजेस.
Yeah. Definitely, it will be very helpful because everyone will be useful in this particular forum and discussion, right?
Correct. Thank you, sir. Thank you.
Oh, welcome.
Please speak, ma'am.
So, will there be any role for any assessments in between the term exams, like the earlier tests and assignments, or we'll just evaluate them at the practical as only those competencies will be seen?
Yeah, once again, you can see there are plenty of things which needs to be clarified, right?
Yes, sir.
Ideal CBME should go for a formative assessment and less of a summative assessment, right?
Yes, sir.
Like what we have seen in Queen's School of Medicine.
Yes, sir.
But over here, once again, you can see the assessment booklet which is being published over here. The summative examination is still there, and that is the main examination, right? There is an importance of internal examination, and what, as per the assessment guideline, that internal examination marks will not be considered for university examination. It will be there, eligibility criteria, but it will be there
sir.
on the result. Both will be there. So once again, that would be our difficulty, because internal examinations would be there, but that may not make up a part of summative examinations. Still, summative examination is there.
Okay, sir. But what about in between, sir? Like those 3 months up to the internal assessment, some other kind of assessment ongoing will also happen, right?
Ideal CBME, it has to be day-to-day assessment.
Yes, sir.
Right.
So
but
for
unfortunately,
theory, it is a bit difficult to do it like that, I think. For practical hours, we can have some exercise at the end of each practical, but theory.
You are very right. Because this is not an what we can say. It is not exactly the CBME which is ideal in form, like what we are seeing that in US and Canada, right, where students would pursue their basic sciences, and then once it is there in clinical science, only the focus is acquisition of clinical skill, where CBME would be very important, right? Over here, still we are talking about subjects, and along with that, acquisition of skill. So there will be some limitations of that.
Thank you, sir. Thank you.
Oh, welcome.
I don't see any hands, and thank you, friends. Thank you, Dr. Sanjay. I think we can end it now. Yeah. And at 7 p.m., Dr. Tajinder Singh will be taking another webinar on complementing online assessment. And so from AHP, so please join. Okay.
Okay, thank you. Goodbye.